Hello and welcome to Parkinson's 101, What You and Your Family Should Know. I'm Nancy Nealon, a Community Program Manager for the Parkinson's Foundation. Joining me today from behind the scenes are my colleagues, Sarah and Danielle. We all warmly welcome you to the program today, especially anyone who's joining us for the first time. I'm logged in from Rochester, New York. We'd love to know where you're watching from, so feel free to share your location by typing in the chat box at the bottom of your screen. I'd now like to share some important information about the Parkinson's Foundation with you. Our mission is simple and straight to the point. Every day and everything that we do, we work to make life better for people with Parkinson's. And we have everything you need to live better with Parkinson's. We organize our work under these three goals: improve care, advance research, and educate the global community. The Parkinson's Foundation provides numerous free resources, including starting with our website, parkinson.org, and a whole array of educational booklets, webinars, podcasts, and so much more. I really encourage you to call our helpline. We'll give you that number to visit our website and talk to our great helpline specialists and take a look at all that's available for you, including individuals who are newly diagnosed. Today, we thank Neurocrine. I'd like to acknowledge the support of these two generous organizations. This webinar is brought to you in part by the generous support of Neurocrine Biosciences. At the end of this webinar, we'll share a brief video. And for more information about Neurocrine and their Cards for Heroes program, visit www.neurocrine.com. In addition, I'd also like to recognize the amazing support from the Light of Day Foundation. Their generosity has made PD Health at Home programming possible. Thank you so much, Light of Day. At this time, I'm honored to welcome and introduce our first presenter. Dr. Yori Freischmann is a fellowship-trained movement disorder neurologist with a special interest in understanding the needs of individuals and families who are living with Parkinson's disease and related disorders. She also has a special interest in designing new models of care to better serve this population. After 3 years on the faculty of New York University, she joined the Rush University Medical Center Parkinson's Disease and Movement Disorders program in 2017. Once Dr. Fleischer's presentation is done, we will then welcome Dr. Matt Burns for our live moderated Q&A session. Dr. Burns is currently a senior fellow at the Norman Fiksel Institute for Neurological Diseases in the Neurology Department of the University of Florida College of Medicine. He received his MD and PhD from the University of Illinois. He also received neurology residency training at the University of Chicago and went on to receive fellowship training in movement disorders at the Fiksel Institute with Dr. Michael Oken, our medical director, where he won research awards from the Parkinson's Foundation, Pepper Foundation, American Academy of Neurology, and the National Institute of Health. So with that, I'm now inviting you to sit back and we're going to turn it over to Dr. Fleischer's presentation. And please remember to submit your questions.
Hi, everyone. Thank you so much for the kind introduction and for the opportunity to speak with you today. I'm so glad that you're here and you're joining this program. So let's talk about living with Parkinson's and what you and your family should know. There we go. So here's what we'll cover today. We'll talk about what Parkinson's disease really is, what causes it, what are some common symptoms, how do we manage the disease so that you can live well, and Parkinson's and research. So what is Parkinson's disease? Parkinson's is a progressive brain disorder. Sometimes we call this a neurodegenerative disease, meaning that there are populations of brain cells or neurons that die off before they should. And there's nothing that you did to make this happen. There is no cure right now for Parkinson's disease, but symptoms can be treated, and there's tremendous reason for hope. Parkinson's can affect movement. We think of it as a movement disorder, but it can also affect a number of other symptoms and systems of the body, including mood and thinking. Healthy lifestyle choices can help maintain quality of life, and we'll dive into that in a bit. But if you take nothing else away from this presentation, please know that people with Parkinson's disease can live well for many, many years with expert care, support, and the right resources. You don't need to do it alone, and we are here to help. So, who gets Parkinson's disease? I think a lot of people are surprised when they hear these numbers, but an estimated 1 million people in the US have Parkinson's disease, 10 million or more worldwide, and 60,000 people are diagnosed with Parkinson's every year. It's the second most common neurodegenerative disease after Alzheimer's disease. Parkinson's can affect anyone. Parkinson's doesn't care about race, ethnicity, gender, or sex. And most people are over the age of 60 when they're diagnosed, but a small number have what we call young onset Parkinson's disease or early onset Parkinson's disease. And this typically means being diagnosed younger than 50. And there's a very, very small fraction of people who are diagnosed earlier than that, so in their 20s or even earlier. And we refer to those individuals as having juvenile onset Parkinson's disease. But again, that's exceptionally rare. So what causes Parkinson's disease? Age is the #1 risk factor for developing Parkinson's disease. The older a person is, the higher the risk of developing Parkinson's. Overall, though, the cause is unknown. Scientists believe that it's a combination of genetic and environmental factors that contribute to an increased risk for most people. So Parkinson's is rarely hereditary in the sense that only a small number of people have a gene that runs in their family that guarantees that they will develop Parkinson's disease. That's fairly rare. There are several genes that have been identified and that can be tested for, where if the person tests positive for those genes, we know that they have a higher risk compared to someone else in the population who doesn't have that genetic change, but it doesn't necessarily guarantee that they will develop Parkinson's disease. And for some people that have Parkinson's, frequently they ask, even if they have been genetically tested and confirmed to have one of these mutations, what does this mean for my family? Having the mutation themselves doesn't necessarily mean that their loved ones will have that mutation, or if they do, that a loved one with that mutation will necessarily develop Parkinson's themselves. So it increases the risk, but doesn't guarantee that a person will have it. Let's see if we can. In addition, there are some studies that have demonstrated that prolonged occupational exposure to certain chemicals like certain pesticides, heavy metals, and solvents, or even air pollution are associated with an elevated risk of developing Parkinson's. But again, to be put into context is that many, many people are exposed to these things who do not develop PD. So it's not, spraying pesticides on your lawn on the weekend in the summer. That's not what did it. We don't think. It's probably a combination of many things. So I like to think about this as almost a combination lock. You need the right setup genetically and the right setup of environmental things, and they have to line up in just the right way, or maybe just the wrong way, and that leads to Parkinson's disease. So there are other risk factors, as I mentioned. Older age is the biggest risk factor. There's studies reporting that certain traumatic brain injury can be associated with Parkinson's. I want to comment on the thought that this comes up in the clinic frequently, is that sometimes people will say that symptoms appeared suddenly after a severe shock or a severe stressor. There are descriptions like this, in fact, dating back centuries. But Parkinson's is very slowly progressive. By the time movement symptoms arise, Parkinson's has been going on for years in the background, maybe with very subtle symptoms that we only recognize when we really dig deep and ask questions. And maybe there were no symptoms that were noticeable, but it seems unlikely that any single event causes the disease. For example, I have a patient who swears that their snowblower caused their tremor. They were fine until that great blizzard when they got the snowblower out. But when we dig back, they had some other non-motor symptoms and constipation and all kinds of other things. And just based on the science, it's probably not the snowblower's fault. They were probably en route to developing full-blown PD anyways. So what's really happening in the brain? let's dive into this. So here, hopefully you can see my pointer. So Parkinson's occurs when the nerve cells in the brain that produce a neurotransmitter or a chemical called dopamine start to malfunction and die off. So if we look over here, this is a normal neuron, and this is the end of the neuron. This is sort of the fingers reaching out to communicate with the neighboring neuron that needs to receive dopamine. So this neuron makes dopamine, releases it into this space, into the synapse, and the dopamine goes to this dopamine receptor neuron, turns it on, and that leads to normal movement. So in Parkinson's, for reasons that we still don't understand what sort of starts this cascade, these dopamine producing neurons start to die off over time. So there are fewer and fewer of them. And so there's less dopamine being released. The dopamine receptors are still there. They still need to see that dopamine in order to work on lots of functions in the body, including coordination of movement, so the speed of movement, but also speech, sleep, cognition, mood, and more. And what we used to think of as really a dopamine disease, although that was sort of the first thing described in Parkinson's, we now know that other neurotransmitters, other chemicals in the brain are also affected. And this includes things like norepinephrine, acetylcholine, and serotonin. And I bring this up because those chemicals really help mediate mood and lots of other functions in the body. And so we will talk soon about mood symptoms in Parkinson's and other things that go on. These are as much chemical changes as the tremor and the movement symptoms that we think of more frequently. So researchers are working on ways to stop or slow down the loss of these cells. So what should you know about symptoms? Parkinson's affects many systems in the body, including mood and thinking. And we call Parkinson's a movement disorder. I'm a movement disorder specialist because we think commonly of the tremors, the slowness of movement, and the stiffness that it can cause. Symptoms vary from person to person. We can't say this enough. If you've seen one person with Parkinson's, you've seen one person with Parkinson's. If you get the sense going to a support group or an exercise class for people with PD that everyone else has different symptoms and they're all on different medication regimens than you, you're right, because everyone has a sort of different presentation of their PD and needs something a little bit different. So let's talk about some of the motor symptoms first. So tremor or shaking, which looks like this, or could look like that in a foot or in the jaw. Tremor is often one of the things that brings people to care. It's a noticeable symptom for many people. Typically, it's in the hand or the foot, but it could be in the head, neck, or jaw. It's often the most recognized symptom, but not all people with Parkinson's develop a tremor. So about 30% of people with Parkinson's never have a tremor. And we call this a resting tremor, which means that for the most part, early on or throughout the course of the disease, that tremor is there when you're not using that hand or that foot, when it's just resting on the arm of the couch or sitting, close to the keyboard, but you're not typing. That's when you might notice it, or often when a family member might notice that the hand is shaking. And if you look at it, if you pay attention to it, if you move it around or change positions, you can make that tremor go away for a certain period of time. Slowness and trouble with movement, though, or this fancy word of bradykinesia. So this is really the hallmark of Parkinson's disease. You really can't be considered to have Parkinson's disease without bradykinesia. It's the slowness and the decrement that really leads to this diagnosis. So your doctor may have you tap or clap or do these funny movements. And what we're looking for are, do the movements stay big and large, or are they slower instead of fast? Do they get smaller as you go and teeny tiny taps? That's really the hallmark of Parkinson's disease. This can show up in daily life in subtle ways. So more difficulty taking longer to button tiny buttons, to do cuffs, to zip zippers, to prepare food, to brush your teeth, starting big on one side, but getting tiny and more cramped as you go. Shaving can get difficult. And often because these changes are very slow and they don't happen overnight, thankfully, if we ask a person, they may say, no, I've always been this slow, or, I've lagged behind the group when we're walking for years, but those may be subtle earlier symptoms. Stiffness can be common, stiffness in the arms, legs, neck or hips, and trouble with walking and balance. Let's talk about some of these non-motor symptoms. So as I mentioned, mood is a very common symptom. So depression can commonly occur in Parkinson's. And I want to put a point on, this is not just, I was just diagnosed with Parkinson's, you'd feel sad too. Yes, that is an acceptable and normal response. People have what's called an adjustment disorder when they receive a difficult diagnosis. The depression that we're talking about is separate from that. The depression we're talking about is feelings of sadness, feeling blue, feeling hopeless, feeling worried. And that can start years before a tremor or slowness or stiffness. And that can happen at any point during the course of the disease. If it is a change from your normal baseline, it may reflect some of these other chemical changes going on that are part of Parkinson's disease. Similarly, anxiety is also a very common symptom in Parkinson's, and it can be a generalized anxiety, feeling more nervous or more anxious than you previously did, or it can be very situation specific. So really getting worried about timing of appointments and needing to leave, or worrying about traffic. And so giving yourself an extra 2 hours, arriving at the office very, very early. All of these, if they're changes, you should talk with your doctor about them. Also, apathy, this sort of lack of motivation, lack of feeling or interest, even separate from depression. So just feeling kind of loss of oomph to do the things that you would normally want to do. That's very common. So Parkinson's can affect cognition or thinking and memory in terms of trouble paying attention, trouble learning new things, trouble finding the words that you want to find, slower thinking, even if the quality of the thinking is great, and difficulty remembering words or names. Frequently, this starts with that tip of the tongue phenomenon. The person standing in front of you, you can't think of their name. And as soon as they walk away, of course, you remember their name. And while these all can happen with normal aging, they're more common with Parkinson's. Sometimes people have trouble with softer speech, or as they get to the end of their sentences, they start to trail off and it becomes harder and harder to hear them. Sometimes people have difficulty falling asleep or staying asleep, and people can have what's called a Rem sleep behavior disorder, which is, and this can precede motor symptoms by many years, if not decades. Instead of having vivid dreams, but if a person's in the bedroom next to you, they don't know what you're dreaming about. Rem behavior disorder means you are acting out your dreams. You may be kicking, thrashing, punching, turning over in bed, having loud conversations. It's like the switch that should turn off muscles while sleeping. That switch doesn't get flipped in people with Parkinson's. People can report fatigue. So even if you do have a good restful night of sleep, still feeling very sleepy during the day or having little energy. Constipation is incredibly common, and hallucinations, typically later in the disease. So this is a great, just sort of a handy reminder of 10 early signs of Parkinson's disease. We've covered several of these, but tremor, small, cramped, tiny handwriting or micrographia, loss of a sense of smell. And I want to highlight that this is not COVID related. Parkinson's was associated with a loss of sense of smell long before COVID. And this is typically gradual. This is not sudden in onset. Trouble with sleeping, as I mentioned, trouble with moving or walking. Constipation is a big one. Soft or low voice, a masked face or diminished facial expression, dizziness or fainting, especially upon standing up or changing positions, feeling a little bit lightheaded, and a stooped posture or hunched over posture. So how do we diagnose Parkinson's disease? The only way to diagnose Parkinson's disease with 100% accuracy, 100% certainty, is to look at a person's brain under a microscope, which is not something that we do while a person is still using that brain. So how do we diagnose Parkinson's then with some degree of certainty during life? Making an accurate diagnosis in its early stages especially can be difficult, but a skilled physician can come to a pretty reasoned conclusion that this is Parkinson's disease with a high degree of accuracy. It's important to remember that 2 of the 4 main symptoms must be present over a period of time for a neurologist to consider a PD diagnosis. And those symptoms are bradykinesia, that's slowness and movements getting smaller. You have to have that. And then one of the following 3, which is that tremor, especially at rest, rigidity or stiffness of the muscles, and postural instability or changes with walking, changes with balance, or falls. If you have that bradykinesia, the slowness, and one of those other three, then we're in that category of Parkinsonism. So a detailed history, the reason that your neurologist or that the doctor will ask you 1,000 questions is to rule in or rule out Parkinson's disease, to try to get as close to certainty as we possibly can. They will ask about your medical problems, current and past medications, and then do a neurological exam to assess characteristic motor and non-motor features. So frequently we will use something like the Unified Parkinson's Disease Rating Scale, or UPDRS, which is those tappies and clappies and this and watching you walk and wiggling around your arms and legs. And it may feel a little bit silly, but it really is quite meaningful. And especially standardized exams like that can tell us how a person changes over time, how a person changes in response to starting a medication. And so that's very, very useful. You don't need to practice the taps and claps in the car on the way to the doctor's office. People frequently ask about a DAT scan, which is a type of brain imaging, and this is usually not necessary to diagnose Parkinson's disease. If you have classic symptoms and the exam is consistent, the DAT scan does not tell us much more. And when we compare it to a movement disorder specialist, the doctor tends to perform better than the scan, because the scan doesn't have the benefit of learning all about you. So when do we start treatment? The bottom line is the decision of when to start treatment is made through a discussion between the neurologist and the person living with Parkinson's disease. We start treatment when you tell us that your symptoms are getting in the way of some portion of your life. If they are crossing a threshold where they are bothersome enough that you want to do something about it, then we should be starting treatment. And again, what that treatment looks like is so different for every person. So you got to build a team. At different points in the Parkinson's journey, you need to seek the support of professionals who can help with treatments and symptom management. And the answer is not always just add on another pill. There's so much more to this. So your team may include a movement disorder specialist or specialty trained neurologist, a general neurologist, your primary care doctor, a nurse, a physical therapist, occupational therapist, speech language pathologist, social worker, psychologist, psychiatrist, pharmacist, the list goes on and on, dietitians, fitness professionals, support groups, community health workers, and more. So where do you start? I would advocate to start by finding your point person, find the quarterback, find whatever sports analogy you want. Finding a qualified physician is the first step. Look for a neurologist who treats people with Parkinson's disease, and when possible, a movement disorder specialist. What does that mean? Movement disorder specialist is a neurologist. They've done 4 years of their residency training after medical school, and then they have gone on and spent 1 or 2 extra years just focusing and training in Parkinson's disease and related disorders. It's all that we think about. So how do you find such a person? Starting with the Parkinson's Foundation, going to the Parkinson's Foundation website, calling the helpline is a great place to start. You can look up a Parkinson's Foundation Center of Excellence or places that have a movement disorder specialist and go from there. So some people may not have a specialist in their area or a doctor who knows Parkinson's well. Telemedicine may be a good option, but it might also be worthwhile to travel once or twice a year, even if it's far, a farther distance, to see a specialist who can then coordinate your care and work together with a local physician to provide the best possible care for you. It's really important to find someone who you're comfortable with, who's going to take the time to listen and answer your questions. If you don't feel like it's the right fit for you, you know you best, look for someone else, find your team, because it's going to be your team for years to come. So I mentioned that Parkinson's treatment can include medications, can potentially include surgery for some people, but exercise and other specialized therapies are critical. Exercise, PT, OT, speech, counseling, and therapy. So briefly, we'll talk about medications. Different medications work in different ways. Different regimens are prescribed for different people because everyone is different. Not only their Parkinson's, but what other medical problems they have, what other medications they might be on. There is no cookbook for this. There is no cookie cutter approach to Parkinson's disease. You are too individual. You are too unique. The choice of medicine may be dictated by side effects and tolerability. It may be dictated by the symptoms that bother you most. In general, levodopa is sort of our oldest, our standby. It is both our safest medication and our most powerful. And rarely are those two characteristics found in the same medication. So why is this? Well, levodopa, once it crosses the blood-brain barrier, which is kind of this protection system, it's almost like saran wrap around the brain. Once levodopa gets to where it needs to go and gets to your brain, it's converted to dopamine. So I told you before that Parkinson's is often thought of as a dopamine issue because you're losing your own dopamine. You're not producing as much. Well, levodopa gives you back your dopamine. It's sort of like if someone is B12 deficient, we give them back B12. We don't give them back some B9 and some B3 and kind of hope that it adds up together. But levodopa can have side effects just like any medication. And so we have other alternatives. We have other things in our toolkit. We have medications that kind of mimic dopamine, so dopamine agonists. We have MAOB inhibitors, and these are medications that aren't quite as strong, but they block the breakdown of dopamine. They kind of prevent it from being recycled. They keep it in the neighborhood a little bit longer. And similarly, COMT inhibitors, they also kind of boost the efficacy. They kind of increase the levodopa that we're giving you. They keep it around for a little bit longer. So surgery can be an option for some people, not for everyone, but surgical options can be explored if symptoms aren't well controlled with medication alone. So what are we talking about? Deep brain stimulation has been around for quite some time. This is almost like a pacemaker in the brain. So instead of treating the issues going on in Parkinson's with chemical medication, we can replace some of that chemical medication, not usually all of it, but some of it with electrical stimulation. No, you don't feel shocks, but it does help, particularly with tremor, particularly with people that are getting a lot of fluctuations where the medicines work and then sort of don't work, and you go through cycles throughout the day, or a lot of dyskinesias, a lot of extra fidgety, wiggly movements. That's who deep brain stimulation typically tends to work the best for. Duopa is another option, and this is an intestinal pump, sort of like a feeding tube in a way, but it is a small tube where the levodopa is delivered directly to your intestine. It's like a slow, continuous drip of levodopa, and that's used to treat motor symptoms. These can be wonderful treatments for the right patients, but surgery isn't right for everyone. So like any therapy, talk to your doctor about whether this is an option for you. What is and should be an option for everyone is exercise. So everyone knows that they should be exercising more. This talk is being recorded at the beginning of January. We've all made our resolutions, right? Stick to them, especially people with Parkinson's. Why? There's all kinds of reasons, but we know that people with PD who start exercising early after their diagnosis, even if you've been a couch potato up until now, if you start exercising now and you can get to a minimum of 2.5 hours a week, 30 minutes, 5 times a week, you will experience a slower decline in your quality of life compared to the folks that are still sitting on the couch. So even if you haven't been an exerciser, you are now, you can be now. So why? Exercise helps maintain balance, mobility, strength, and flexibility. This is critical. Some of the things that can wind people with Parkinson's up in the hospital are falls. So even if you have no balance issues right now, fantastic. Let's build on that strength and get better and more stable. Exercise can also help to ease secondary symptoms like mood and constipation. Exercise programs should include flexibility and stretching exercises, aerobic activity, stuff that really gets your heart rate up, gets you sweating a little bit, and resistance training. And people frequently say, okay, but what's the best exercise? Like if I'm going to buy one piece of equipment, it's the thing you'll do. It's the thing you'll stick with and enjoy. I am not a runner. Running is never going to be the thing that I do, but find the thing that you love. If that's biking, if it's running, if it's Tai Chi, if it's yoga, if it's Pilates, if it's boxing, if it's karate, if it's dance, if it's, walking your dog or chasing after the grandkids and playing a really vigorous game, do it. If you can switch it up and incorporate a few things, even better. But do whatever you will stick with and enjoy. Why? Because exercise is fundamentally changing the brain. There is neuroplasticity, so helping your brain change over time in good ways, right? Helping the brain maintain old connections, form new ones, try to restore lost ones. You're basically nurturing the environment of your brain by exercising, by reducing toxic chemicals, increasing the production of other chemicals that help sort of sustain the brain and nourish the brain by exercising. So who can help you with this? Physical therapists are whizzes at keeping you moving as well as possible, as long as possible, and enhancing your ability to move. They can show you how to use those random machines at the gym. They can show you what you can do from the comfort of your own home, what you can do in your neighborhood. You can tell them, here's what I'm struggling with. You can practice falling and then getting up. It sounds silly, but it's critical. Occupational therapists often work on how you can adapt activities of daily living, how to do things better, using your personal strengths, changing your environment, and adapting activities. Speech language pathologists are critical to help maintain communication skills, strengthen them, strengthen your voice, and combat swallowing difficulties. So early intervention, especially if there's any change in swallowing, is really important because there are things that we can do about it. So people often find this surprising, but depression and anxiety are the #1 factors impacting the overall health and well-being of people with PD. It's not the tremor, it's not stiffness, it's mood. And this makes a lot of sense because if you're sad, if you're feeling blue and that's untreated, if you're feeling stigma against yourself for feeling blue, you're not going to take your meds, you're not going to exercise, you're not going to do all the therapies, right? And so this is treatable. It is important. It is imperative that we treat it. So mental health support for the person with Parkinson's disease, treating the mood disorders, whether that's with medication or non-medication strategies, discussing the challenges of living with Parkinson's disease, building coping skills throughout the PD journey is important for the person living with Parkinson's disease, but is equally important for the mental health support of the family, the friends, the care partners surrounding that person with Parkinson's disease. This is not a disease that affects an individual. This is a disease that affects a family, a partnership, an orbit of everyone that's living and being with that person with Parkinson's. Mental health support can be provided in numerous ways, and this is not an either or, this is an and or all of the above. Support groups, social workers, counselors, psychologists, neuropsychologists, and psychiatrists. There are so many challenges of living with Parkinson's disease, and this is just scratching the surface, but unpredictability, sense of control or lack of sense of control, loss of independence, changes in lifestyle, changes in roles, changes in identity, but there are so many things that you can do about these, that your loved ones, that the team that you build around you can help. So what do you do about unpredictability? There's some thought that getting comfortable with unpredictability and with a sense of control, knowing that, some days you may need to go with the flow. Some days won't be great days and some days will be great days. Sometimes you can predict that and sometimes you can't, and kind of riding that wave when you can. Finding things that you can take ownership of, your exercise routine, how you think about Parkinson's, how you talk to yourself about Parkinson's, and your attitude. Instead of thinking about what things you can't do or that you might need more help with, thinking about what you can do and reaching out to physical therapy, occupational therapy to maintain your independence, to find ways around and workarounds. Reconfiguring your lifestyle. If there are things that are hard, it doesn't mean you need to give it up, but can you work those a little bit differently? And instead of reflecting on roles that may change, finding the light in those roles that have changed, creating new roles for yourself, and reflecting on your identity. Parkinson's should never define you. This is not who you are. This is a thing on your list. This is part of your life. It is not the entirety of your life. And how do we make it less and less a part of your life? We move forward. We develop new treatments. We find new answers. We figure out the unmet needs for people with Parkinson's, and we try to meet those needs. And the way that we do that is through research. Truly, research plays a vital role in helping us understand Parkinson's, and there's a research study for everyone, for anyone. Research leads to new treatments and medications. Research doesn't mean necessarily a clinical trial. It might mean a survey. It might mean participating in a behavioral intervention, a program, an exercise study. It could be anything. But research provides us better understanding of symptoms and disease progression. 10 years ago, we would have said, no, vision doesn't change in Parkinson's. That's not a thing. We know now that it is. We used to think pain wasn't a part of Parkinson's. We know now that it is. And all of this is because of research. So how can you get involved? Ask your doctor, ask your movement disorder specialist, reach out to the Parkinson's Foundation, look at clinicaltrials.gov. You can go on this website, type in Parkinson's disease, type in a radius of how far you'd be willing to travel to participate in a study, and boom, you get this list of all of the different studies going on to look at Parkinson's. And even if you don't want to participate in a trial, but you just need a little shot of hope on one of those bad days, go look at clinicaltrials.gov, see how much is going on. Research has not stopped in Parkinson's because of COVID or anything else. Everyone is still really hard at work trying to make this a thing of the past. So in conclusion, Parkinson's does not define you, and Parkinson's can be treated effectively. Symptoms vary from person to person. You will never meet someone else with the same Parkinson's as you, and it can include both movement and non-movement symptoms. A personalized treatment approach with a comprehensive team of providers can help individuals have the best long-term outcomes. Critically, a support network is helpful for people with Parkinson's and their families. You cannot go it alone. You should not go it alone. We are here to help you, Parkinson's specialists, all of the team, and the Parkinson's Foundation. So with that, I want to thank you so much for your time, for putting in the effort to learn more about this disease. It will only make you stronger. Thank you so much.
Dr. Fleischer, thank you so much for such a wonderful presentation. That is a lot of information, of course, that we just presented to all of you. And I know some of you are very new to Parkinson's. So at this point, I am so happy to welcome Dr. Matt Burns, who is going to handle all the questions that you have submitted from both registration and those that came in during the presentation. We'll try and get to as many as possible. Dr. Burns, welcome. So good to see you.
Thank you. Glad to be here.
As I was saying a moment ago, there's so much information that we tried to fit into this presentation. I was wondering if we could just go back based on some questions. Could you briefly summarize, someone asked, what are the signs of Parkinson's? Could you maybe run through that once again
Sure.
for us?
So the way we make the Parkinson's diagnosis is we look for four cardinal symptoms, four classic motor symptoms. Those symptoms are tremor, slowness, stiffness, and gait instability or balance problems. And to make the diagnosis of Parkinson's disease, you only need two of those. So for example, you don't need a tremor at all. I have Parkinson's patients who have no discernible tremor, but they have slowness and stiffness, or that they are slow when they walk and they have balance problems. That is sufficient to make the diagnosis. And additionally, in particular, the tremor, slowness, and stiffness have to be of a particular quality. So it has to be a rest tremor, something that can be there when you're driving or writing, but is more prominent when you're sitting in a chair watching TV, for example. And then the slowness is a particular kind of slowness that we see on exam. Often movement disorder specialists will have people tap their fingers or open and close their hands. And then the stiffness is not just kind of aches and pains that may come with age. It's a particular kind of stiffness we call rigidity, which we also feel on exam. So, so you need those to make the diagnosis. Now, Parkinson's patients may have a whole host of other symptoms, non-motor symptoms, as Dr. Fleischer mentioned, and prodromal symptoms, which are things that can happen before the tremor, slowness, stiffness, or balance even begins. But those other things are not consistent enough to make the diagnosis on their own. It's those four key features, the combination of which makes the diagnosis.
Great. And I'll follow up with, once again, another topic that was covered, but I think it's so important if we can just review it again. A person asks on behalf of their spouse that he was just diagnosed. He's seen a general neurologist. How important is it that a neurologist who specializes in Parkinson's, and in this world, that's called a movement disorder specialist? How would you respond, Dr. Burns?
Well, I'm biased because I am at a referral center, a specialty center, and it's sort of what I do all the time. So I think that it's probably of value to see someone like me at some point early on in the diagnosis, to get a sense of what the considerations are, what what's worth looking out for. And often specialty centers just have access to supportive services like social work, physical occupational therapy. We have a dietitian, we have a geneticist. We tend to be more plugged into clinical trials. And so if you're newly diagnosed, there's nothing wrong with double timing or triple timing your doc. See your general neurologist because they're close and accessible and you have a relationship, but maybe check in with that specialist once every year or 18 months. We do that frequently, and that's perfectly fine. In the age of telemedicine, it's easier still to do that. That's probably what my advice would be.
Indeed. Okay. Very good. And I'll just add that, and we'll share this number and the email at the end. I know it's hard to keep track of all this information. We have so much coming at you, but the Parkinson's Foundation helpline, the helpline specialist, you can email them. You can get direct information on all of this directly from us.
Yeah.
Next question is about genetics. And this is something else that the Parkinson's Foundation is very, very much a priority area. So is genetic screening for Parkinson's possible? And could CRISPR, I'm going to pronounce the acronym, CRISPR, potentially provide a cure in the future for individuals with genetic predisposition?
I think that's a possibility, although right now that technology is being applied almost exclusively in the research context. And I think, so I think there are a couple of considerations that make that technology not quite right for prime time. The first is for the known genetic mutations that cause Parkinson's disease. Often it's not completely clear what the normal gene does, or all the things the normal gene does. And so if you have a technology that cuts out, removes a mutant gene, you may be blocking a normal physiologic process, cellular process. And then the technology itself has some limitations and uncertainties. That the extent, the accuracy of the technology's ability to insert or remove just the gene and not important genetic material on either side of the gene, for example, or remove not only the targeted gene but other unrelated genes. That's we as scientists don't have complete confidence that the technology is that absolutely accurate, and so it remains in the research context, and I think it probably will remain that way for a while still. I think beyond the technical concerns and just the physiologic concerns, the idea that a therapy would alter the genome of human beings is something I think that is not out of the realm of possibility scientifically, but is something that the public needs to consider in a thorough, examined way. We need to have a discussion, a lengthy discussion about that in the media and in Congress. And what does that mean? What are the limitations? Under what contexts? That's an important component of that kind of therapy.
So in other words, it's pretty complex and complicated.
Multi-layered issue, and an issue that will take a fair amount of time to address adequately.
I'll add that for any of our viewers who are interested in genetics and Parkinson's, please once again go to our website, parkinson.org. Right on the landing page, about the middle, you will see, and you can read all about our PD generation efforts and the research that's happening there. So I encourage you to do that. Okay, Dr. Burns, next question. So what's your opinion on medical marijuana for Parkinson's?
Oh, I knew this would come up.
It normally does. It normally does.
Yeah, so I have a lot of patients who are taking one form or other of medical marijuana. It's gummies, CBD, the smokable stuff, brownies, whatever. It's a hard question to answer, and that's because as a physician scientist, I'm obligated to give patient guidance based on existing evidence. And there's an upside and downside to that kind of approach to advice giving. On the one hand, when I give advice, I feel I have a high level of confidence about my advice because it's been vetted through multiple clinical trials and meta-analyses and all that stuff. So But the downside is it really limits what I can advise, because there are many things that are just not amenable to that kind of research, or just has not been adequately addressed in that kind of rigorous way. And marijuana falls into that latter category. There is just not sufficient research to understand the benefits or where it's kind of useless. And so as a result, my advice relies largely on what patients tell me, which is like the medical version of gossip. And as far as a kind of quality of evidence, that's very low. Even if I see a ton of patients and I read as much as I can, that's still a low level of evidence. So with that as a big caveat, what I would say is, out of 100 Parkinson's patients who have at some point tried one of those things, most, by the numbers, say, I tried it, didn't do much. Of the minority that say it helps with something, they tend to tell me it helps with sleep, it helps with anxiety, it helps with appetite. And then maybe to the extent that a patient's tremor or slowness or stiffness is made worse by sleep, anxiety, or appetite, then those other symptoms get better along with the marijuana. So if you've got poor sleep, problems with anxiety, or your tremor gets much worse when you're excited or anxious, I think worth trying. Probably low risk, probably will not interact with other meds. But the other consideration is medical marijuana can be expensive. It's kind of a hassle. You got to go see a doc, see him a couple times, you pay for the card. This is for the medical marijuana. So you got to go jump through those hoops. That's expensive. Then you got to buy the stuff. That's expensive. The gummies, the CBD, it can add up. So on balance, for something that by the numbers isn't a game changer, if you've got some disposable income, worth trying. But and that's really all I can say about it. But no significant risk or harm, except to your pocketbook, maybe.
All good things that someone can consider as they think about that and what they'd like to do. We know that certainly as the disease progresses, fall risk can be a big concern. But there's someone who writes in today that actually just upon recent diagnosis, part of the problem is vertigo, and that this individual with vertigo took a bad fall. So what would you suggest? Is there anything medication-wise, therapy-wise to help with vertigo?
So when patients talk about dizziness or vertigo, usually a good neurologist should push them a little bit on exactly what they need. So some people have what's called benign paroxysmal positional vertigo, where they roll over in bed, or they stand up or bend over, tie their shoe, and all of a sudden the room starts spinning. It happens like that. It can be bad, makes you sick, people throw up. That is largely unrelated to Parkinson's disease. And although as a movement disorders doc, we try and explain all the symptoms with one diagnosis, some people have both Parkinson's and benign paroxysmal positional vertigo. So that particular person may just have two different diagnoses. They may just be that lucky. But Parkinson's patients sometimes can have drops in blood pressure. It can produce a kind of a lightheadedness. Room doesn't spin, but when they stand up, especially quickly, or they feel more unsteady, or that they might faint. And sometimes people will describe that as vertigo or dizziness. So that can be the result of the disease, can be the result of medications meant to treat the disease. And there are medications sometimes that we can give to keep people's blood pressure up enough so that doesn't happen. So my advice would be just talk to your neurologist, movement disorders or general neurologist, and be clear about exactly what symptoms you're having to try and parse what's going on.
Okay. Dig a little bit. Dr. Burns, I think you know that this is this next topic or question is very important to the Parkinson's Foundation. And I don't know, but I'm guessing perhaps in Florida, there are a number of people who English is not their first language. But we have someone who's writing in, their dad is older. He's not a native English speaker. It's not his first language. How would you recommend that the family help support him through either support groups, therapists? There's so many barriers for him, and it's probably very difficult to understand all of this.
That can be a challenge. Ideally, whatever neurologist that person is seeing should be able to take the time to get a professional translator, either over the phone or Zoom. Practically speaking, sometimes that's a challenge. And increasingly, because the community of physicians is increasingly diverse, there are increasingly doctors who speak Mandarin and Tamil and Spanish and Turkish and all that stuff. But it does take some effort to find those folks. I would probably advise that they go through the foundation, the Parkinson foundations, for example. Those foundations are excellent at identifying doctors with those skill sets, and then and maybe contact those specialty centers to try and set up a telemedicine visit.
That's a great idea.
That's probably how I would do it. That's a tough situation.
And although the person who asked the question didn't specify, but if in this case your dad is Spanish speaking, we do have individuals who answer our helpline who are bilingual. So please call us if that's the case. If he's not Spanish speaking, call us anyway, 1-800-4PD-INFO. We'll still try and help make those connections for you. Here's another question that comes up a lot, and it's a pretty common question. Dr. Burns, what do you think about the gut microbiome connection?
So it's a compelling area of research, and that's because the evidence linking changes in gut bacteria to disease are consistent with a classic description of the progression of pathology, which was done by Drs. Brock and Brock in the 1990s, describing a kind of progressive advancement of disease starting in the vagus nerve and then ascending into the brainstem. So it's a compelling area. I think that I'm not quite sure what patient-oriented advice I can provide. Right now, that work is being done in animal models and then some in patients, but it's compelling with regard to an area of research. Patients who want to do everything and are keen about that research, so the best way they can optimize their gut microbiome is the sort of standard boring stuff that doctors say, which is eat healthy, a Mediterranean diet, eat in moderation, and exercise regularly. There's nothing more. There's no sort of a fecal transplant or a particular type of antibiotic or supplement or probiotic that has been identified as beneficial. So although that whole area is quite compelling and interesting, it lives almost exclusively in the research world for now and has not produced good, actionable advice for the clinic yet.
Okay, great. Thank you. I'm going to combine two questions because I think it kind of comes under the same heading of just how unique Parkinson's can be from person to person. So the two questions, someone's wondering, how long could I live independently, until what stage? Or what's the average lifespan of a person diagnosed with Parkinson's in 2021?
Yeah, so that is a tough question. And underlying the question is a debate going on in the field about whether Parkinson's is one entity at base or a variety of related disorders that have a lot of common overlap. I would say, in contrast to other neurodegenerative diseases, such as Alzheimer's or ALS, for example, Parkinson's patients don't necessarily die of Parkinson's. They often have to live with Parkinson's. But I frequently have patients who have Parkinson's symptoms. I come in, they come into my clinic, I give them medications, they go back to playing golf, and I've been seeing them for a long time. They've seen other docs before me, and their progression is quite slow. Other people who have a more complicated course or a more rapid course. And so it's tough to say. I would say, as a rule of thumb, how the disease has progressed in the past for you is probably a good indication of how it will progress. So for example, if you've had a slight one-sided tremor, responded well to meds, and progression has been slow, you've fit that description you have for the last 5-8 years, it's probably how it will continue to go. But if it's been, if things have been more complicated, more rapid progression to bilateral symptoms with other non-motor complications, then that probably is the progression that you'll continue to see.
Thank you. So I'm going to try and fit in one last question here, and I'm going to generalize it a bit. People often ask about over-the-counter dietary supplements. Is there anything that you could suggest that helps with anything related to PD?
No, yeah, there are no supplements that have been shown to be effective, and those have been studied with some rigor. I will say taking a whole lot of B6 is probably increases the risk of independent movement disorder related stuff. So be careful. Some people will take B complex vitamins, and B12 sometimes gives people some energy of a short term. Those can have quite high doses of B6. Supplements, I will say that supplements are not rigorously regulated by the FDA. And so you don't know what you're getting in those pills. You really don't. And they can also be expensive. And so in my mind, the lack of rigorous evidence, the small potential for risk among some of those, and the cost adds up to really just not a very good return on investment. I understand the impulse, you want to do everything you can, but there are things that have powerful effects. Dr. Fleisher mentioned exercise. It really is the disease modifying therapy. You know, if exercise were a pill, it'd be $1 billion drug. And so, but supplements right now, there's nothing that's compelling there.
Dr. Burns, I'd like to take this opportunity to say thank you. We covered a lot of territory in a very short time. And on behalf of all of us at the Parkinson's Foundation, thank you so much. I think everyone probably knows this, but I want to say it to be clear. You know, programs like this would not be possible for us to bring to the Parkinson's community without your support, lending your time, your expertise. So thank you so much. We truly appreciate your time and talent and sharing it with us.
That's kind of you to say. It's really a joy doing this kind of stuff, because I know how many questions come up. It's a complicated thing, and really it takes a while to learn about all this stuff if you're new to it. So just for all the listeners out there, just keep asking questions and keep trying to figure it out. I think there are a lot of resources out there and a lot of good things you can do. So.
Excellent. Thank you so much. There are so many wonderful people like Dr. Burns who are here to help. So at this point, we're going to show you a few more slides. And when we're getting ready for that, I'd just like to thank all of you for joining us today. There was a question. You will receive a follow-up email from us. Please be on the lookout for that, because we'll send you a direct link with the recording so you can see this again. But also, we really need your feedback. There'll be a survey involved. So please give us your feedback, take the survey. That will be in about a week, maybe a little bit longer, but it will be coming. So be on the lookout for that. I want to bring your attention to what's happening in May for Wellness Wednesdays. Wellness Wednesdays in May will be devoted to care partners. I know that there's a lot of information on this slide. You can go to our website, parkinson.org/PD Health, and it will all be there for you. Take advantage. There's so much here that you can learn from and be supported by. Call our helpline too. They'll help you navigate through all of this. And I've mentioned the helpline, gosh, how many times now in our website. So here it is, Parkinson, remember no S, parkinson.org, and our helpline, 1-800-4PD-INFO. These are such important resources. Please take advantage. There is so much that we can offer to you. Call them, visit our website. If the Parkinson's helpline staff don't know an answer, I have witnessed this. They will do everything they can to track down information for you. And if you're newly diagnosed, there is a brand new newly diagnosed packet. And lastly, before we go, I ask you to stay tuned for just a moment. We have a very brief video from Neurocrine Biosciences that we'd like to share with you now. So stay safe, stay well, everyone, and thank you for joining us today.
So I was diagnosed with Parkinson's in September of 2018. Yeah, things have changed. It never really even occurred to me that my handwriting could go too.
He used to write these silly little notes. Sometimes they rhyme.
But now it's so difficult, I just kind of gave up.
It's a common problem in Parkinson's disease called micrographia. Fine motor exercise, including practicing writing by hand, can help. If they could just stay motivated, it would make such a difference.
We sent out kits of custom greeting cards to people with Parkinson's across the nation. We're asking them to join in on writing and transcribing letters of gratitude to our heroes, frontline medical workers. Now they've got a real motivation to keep writing and keep practicing their handwriting.
Here's how it works. People with Parkinson's or their loved ones can sign up at pbcardstoheroes.com to receive their kit of custom cards. When they're done, all these heartfelt handwritten cards are then packed up and sent to our heroes.
Dear hero, I once heard a civilian tell a deploying soldier to stay safe. He responded, if I wanted to stay safe, I would have stayed home. You've chosen not to stay home, and we cannot thank you enough.
That's really amazing.
It means a lot. Thank you.
It's amazing, the spirit of people. They keep fighting, so we got to keep fighting too.